Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast.
Today we're looking at a condition that often starts with a headache but quickly reveals a much deeper complexity: spontaneous intracranial hypotension, or SIH.
Right. It's a field where our understanding of the causes, the diagnostic imaging, and the treatment options has evolved substantially in just the last few years.
And a new review article captures that evolution nicely. It's titled Recent Updates to Diagnosis and Treatment of Spontaneous Intracranial Hypotension, published in the May 2026 issue of the Korean Journal of Radiology.
Okay, so let's start at the beginning. At its core, what is SIH?
It's a neurologic condition caused by a spinal cerebrospinal fluid leak. The loss of CSF volume leads to a whole host of symptoms, the most famous being an orthostatic headache, one that gets worse when you stand up.
But the paper's quick to point out it's not just headaches. It can manifest as vertigo, tinnitus, even findings that mimic frontotemporal dementia.
Exactly. It's a wide spectrum. The diagnostic journey usually starts with a contrast-enhanced brain MRI.
Looking for those classic signs like dural enhancement, venous sinus distension, and brain sagging, among others.
Correct. And the paper mentions the Burn score, which is a quantitative system that assigns points for those findings to predict the probability of finding a spinal CSF leak on myelography. It helps standardize the reads.
But what if the brain MRI is normal? Does that rule out SIH?
That's a critical point they make. Up to 20% of patients with SIH can present with a normal brain MRI.
20%? That's a non-trivial number. So a negative brain scan doesn't close the case.
Not at all. The next step is an MRI of the spine, which is looking for two main things. First, evidence of extradural CSF.
And the paper makes a distinction here. It could be a well-defined collection, what they call a spinal longitudinal extradural collection, which suggests a chronic dural tear.
Precisely. Or it could be more subtle, just ill-defined CSF signal mixed in with epidural fat, which might point to a more acute tear. The authors stress that fat-suppressed T2-weighted imaging is critical for spotting either one.
Okay, so extradural fluid is the first target. What's the second?
The spinal MRI can also detect spinal meningeal diverticula, which are these little outpouchings of the nerve root sleeves. These are important because they are often associated with certain types of CSF leaks.
Which brings us to one of the main updates in the field, a more refined classification of the leaks themselves.
You nailed it. The review breaks them down into three primary types.
Let's walk through them.
First, you have ventral dural tears. These are physical defects on the front surface of the dura, typically caused by a sharp bone spur or a disc osteophyte complex. Figure 1 in the paper has some really clear examples on CT and digital subtraction myelography.
Got it. A straightforward tear. What's the second type?
Lateral dural tears. As the name implies, they occur on the side, most often near the axilla of the nerve root sleeve. The paper notes these are frequently associated with arachnoid herniations, where the arachnoid membrane pokes through the dural defect. Figure 2 shows this anatomy very clearly.
And a third leak type.
CSF venous fistulas, or CVFs. This is a very different mechanism. It's a direct abnormal connection between the subarachnoid space and the surrounding venous plexus.
So the CSF isn't pooling in the epidural space, it's draining directly into a vein.
Exactly. That's why patients with CVFs typically don't have those large extradural fluid collections on their spine MRI. The CSF just disappears into the bloodstream. Figure 3 provides some great illustrations of the different venous drainage patterns seen with these fistulas.
Okay, so we have these three distinct leak types. How do you actually find them? The initial MRI just gives you clues.
Right. To pinpoint the leak, you need advanced myelography, and the paper's first point here is about technique, emphasizing that patient positioning is the single most important determinant of success.
You have to use gravity to get the injected contrast to the site of the leak.
Precisely. If you suspect a ventral dural tear, the patient needs to be prone. If you're hunting for a lateral tear or a CVF, they need to be in a decubitus position.
And they also provide some practical guidance on contrast volume, which seems really useful.
Yes, it's a key technical pearl. For localizing dural tears, where you might be looking for a stream of contrast, they suggest relatively small volumes, around 3 to 8 milliliters.
But for CVFs, the goal is different. You need to fill the nerve root sleeve diverticula to see the fistula itself.
Right, so for that, they recommend larger contrast volumes, typically in the 10 to 20 milliliter range. It's a subtle adjustment, but one that could make the difference in finding a very small fistula.
It's a good example of how the technique has to be tailored to the suspected pathology.
Absolutely. From there, the paper reviews the specific imaging modalities used for myelography, each with its own strengths and weaknesses.
The most common is probably CT myelography, or CTM.
It is. It's widely available and offers fantastic cross-sectional spatial resolution, with slices as thin as 0.6 millimeters. Its main limitation is temporal resolution.
Meaning it's only a snapshot in time.
Correct, though this can be improved by doing what's called dynamic CTM, getting multiple quick scans right after injection. But the real game changer they highlight is the use of photon counting detector, or PCD scanners.
How do those improve things?
PCD CTM offers even better spatial resolution, down to 0.2 millimeters, and faster scan speeds. The paper states these improvements have proven useful for detecting both CVFs and dural tears, enabling sharper images that can reveal very subtle findings.
So it enhances the standard CTM approach. What about other modalities?
Next up is digital subtraction myelography, or DSM. This is a fluoroscopic technique.
So instead of a snapshot, you get a movie. Incredible temporal resolution, seeing contrast flow frame by frame.
That's the huge advantage. The big disadvantage is that it's a 2D projection. It doesn't provide cross-sectional detail.
So you might see a leak, but not know its exact 3D location.
Exactly. To mitigate that, the authors recommend performing a cone beam CT immediately after the DSM. It's a neat hybrid approach that combines the temporal resolution of fluoroscopy with the spatial resolution of CT.
And finally, they touch on MR myelography.
They do, and they're careful to define the term. Sometimes it just refers to heavily T2-weighted MRI sequences to look for extradural fluid.
Which they say are helpful for detection, but typically can't localize the specific leak site.
Right. The other form is intrathecal gadolinium MR myelography. This involves injecting gadolinium into the subarachnoid space and taking T1-weighted images.
And they add a strong note of caution here. This is an off-label use of gadolinium and carries a risk of neurotoxicity if the dose is too high. They suggest they use it only in rare cases.
It seems to be an unpopular option, since the overall yield is lower than CTM or DSM.
Okay, so a whole arsenal of advanced techniques, but the paper then pivots to some clinical pearls, acknowledging that even with these tools, leaks can be hard to find.
Yes, they outline a few reasons for this. First, the leak just might not be where you're looking. Most leaks are in the thoracic spine, so that's where most exams focus, but they can occur in the cervical or sacral spine too.
So you might need to expand the search. What's the second reason?
Some leaks are just occult and may require a second attempt. On a repeat study, they mention using provocative maneuvers like saline pressurization, which has been shown to improve the conspicuity of CVFs.
Or trying a different modality. A leak missed on DSM might show up on a high-resolution PCD CTM.
Precisely. And this leads to what I think is one of the most important diagnostic pearls in the entire review, a major potential pitfall.
Okay, what is it?
Well, the standard diagnostic algorithm is pretty straightforward. If the initial spine MRI shows a lot of epidural CSF, you suspect a dural tear. If there's no epidural CSF, you suspect a CVF.
That's the fork in the road. It determines which type of myelogram you do and how you do it.
Exactly. But the paper delivers a crucial warning. Dural tears can occasionally present with little to no epidural CSF on spine imaging.
Yikes! That completely short-circuits the algorithm.
It does. It can confound the picture and lead an imaging specialist to hunt for a CVF that doesn't exist, while potentially missing a dural tear because they're using the wrong technique.
That's a huge takeaway. It means you can't rely solely on the presence or absence of epidural fluid to determine the type of leak.
You have to keep an open mind. It's a subtle but critical point that could prevent a misdiagnosis.
So once the leak is finally localized, what does the paper say about treatment?
The treatment is highly tailored to the specific leak type, and Figure 4 in the paper gives a nice overview of the different approaches.
Let's start with ventral dural tears.
For those, surgery is often the answer. An open intradural repair allows for direct visualization and suturing of the dural defect. They also mentioned that less invasive endoscopic techniques are emerging.
Are there non-surgical options?
Yes, targeted epidural patching with blood or fibrin glue. CT guidance is key here to deliver the patch as close to the tear as possible.
Okay, what about lateral dural tears?
Both surgery and targeted patching are reasonable options. The authors note that surgical closure generally has a higher success rate, especially for chronic tears or those with large arachnoid herniations.
And for CSF venous fistulas?
There are three main options: surgical ligation of the draining vein, percutaneous fibrin glue injection near the fistula, and transvenous onyx embolization.
The embolization is a clever endovascular approach.
It is, but the paper stresses that both non-surgical techniques for CVFs require exquisite attention to detail to deliver the treatment precisely at the nidus of the fistula.
So zooming out, what's the big picture here?
The big picture is that the diagnosis and treatment of SIH have become much more sophisticated. It shifted from a general diagnosis of CSF leak to a specific, targeted approach based on understanding the underlying pathophysiology of three distinct leak types.
Right. The bottom line is that SIH is not one disease. Successfully managing it depends entirely on correctly identifying and localizing the specific type of leak.
And the imaging tools to do that have become remarkably powerful. From photon-counting CT to hybrid DSM and cone beam CT techniques, these tools allow for a level of precision that wasn't possible a decade ago.
But with a heavy dose of caution, the diagnostic pearls in this paper are just as important as the technology, remembering that a brain MRI can be normal and that the classic imaging patterns have atypical exceptions that can lead you astray.
Well said. It highlights the need for both advanced technology and a persistent, systematic approach when the initial search for a leak comes up empty.
A fascinating look at a rapidly advancing field. That's all the time we have for today.
Until next time on SummaryCast.